Welcome to Medstudent112, your go-to channel for everything medical.
Hello and welcome to this video on Cushing syndrome. Cushing syndrome is a rare condition caused by prolonged exposure to high levels of cortisol, the body's primary stress hormone. In this lecture we will cover the causes, symptoms, diagnosis and treatment options, as well as how individuals can manage life with this syndrome. Cushing syndrome is a rare medical condition that occurs when the body is exposed to high levels of the hormone cortisol for an extended period. Cortisol is produced by the adrenal glands and is involved in regulating various bodily functions including metabolism, immune response and stress response. However, when cortisol levels become excessively elevated, it can lead to a range of physical and psychological symptoms. Pathophysiology of Cushing syndrome. Cushing syndrome occurs when there is prolonged exposure to elevated levels of cortisol, a hormone produced by the adrenal glands. The pathophysiology involves the disruption of normal feedback mechanisms in the hypothalamic pituitary adrenal (HPA) axis, leading to excessive cortisol production. This excess cortisol can have widespread effects on multiple organs and systems in the body. Normal regulation. Under normal conditions, the hypothalamus releases corticotropin-releasing hormone, CRH, which stimulates the pituitary gland to release adrenocorticotropic hormone, ACTH. ACTH then stimulates the adrenal glands to produce cortisol. Cortisol exerts negative feedback on both the hypothalamus and the pituitary gland, reducing CRH and ACTH secretion, which in turn decreases cortisol production. In Cushing syndrome, the normal feedback loop is disrupted. This can occur due to pituitary tumors, Cushing's disease. A tumor in the pituitary gland causes excessive secretion of ACTH, which stimulates the adrenal glands to produce more cortisol. This overproduction of ACTH overrides the negative feedback mechanism, resulting in elevated cortisol levels. Or in adrenal tumors. Tumors in the adrenal glands, either benign or malignant, can directly produce excessive cortisol, independent of ACTH regulation. This can also lead to cortisol excess, even if ACTH levels are low. Ectopic ACTH secretion. In rare cases, non-pituitary tumors, like small cell lung carcinoma, can produce ACTH, leading to increased cortisol production. Iatrogenic Cushing syndrome. Prolonged use of corticosteroid medications, like prednisone, for the treatment of inflammatory conditions can mimic the effects of excessive cortisol, suppressing the normal production of cortisol through negative feedback. Cushing syndrome happens when the body is exposed to too much cortisol for a long time. The causes can be divided into two main groups. First, exogenous cause. This is the most common cause. It happens when a patient takes corticosteroid medications for a long period, such as prednisone, dexamethasone or hydrocortisone. These drugs act like cortisol in the body, so prolonged use can lead to Cushing-like features. Second, endogenous causes. This means the body itself is producing too much cortisol. The most common endogenous cause is Cushing disease, which is caused by a pituitary adenoma. The pituitary gland produces too much ACTH, and ACTH stimulates the adrenal glands to produce excess cortisol. Another cause is an adrenal tumor, such as an adrenal adenoma or carcinoma. In this case, the adrenal gland directly produces too much cortisol and ACTH is usually low. A less common cause is ectopic ACTH production. This happens when a tumor outside the pituitary gland produces ACTH, such as small cell lung carcinoma or bronchial carcinoid tumors. This extra ACTH stimulates the adrenal glands to make too much cortisol. So in summary, Cushing syndrome may be caused by long-term steroid use, pituitary ACTH overproduction, adrenal cortisol producing tumors, or ectopic ACTH producing tumors. Effects of excess cortisol. Excess cortisol affects almost every body system. It increases glucose production, causing hyperglycemia and possible diabetes. It breaks down proteins, leading to muscle wasting and weakness while redistributing fat to the face, neck and abdomen. It suppresses immunity, so patients become more prone to infections and have poor wound healing. It also raises blood pressure by increasing vascular sensitivity to catecholamines and sodium retention, leading to hypertension and higher cardiovascular risk. In bones, cortisol decreases bone formation and increases bone breakdown, causing osteoporosis. In the skin it breaks down collagen, causing thin skin, easy bruising and purple striae. Finally, in the brain, high cortisol can cause mood changes, depression, anxiety and cognitive problems. Cushing syndrome causes characteristic physical changes due to excess cortisol. Patients may develop a rounded, moon-face central weight gain and a fat pad behind the neck called a buffalo hump. The arms and legs may become thin because cortisol breaks down muscle protein. Skin changes include thin, fragile skin, easy bruising, poor wound healing, and purple stretch marks. Patients can also have high blood pressure, high blood sugar, osteoporosis, mood changes, acne, hirsutism, menstrual irregularities, and increased susceptibility to infections. The diagnosis of Cushing syndrome involves a combination of clinical evaluation, laboratory test, and imaging studies to confirm the condition and identify its underlying cause. Given that the symptoms of Cushing syndrome overlap with other conditions, e.g., obesity, depression, a systematic approach is needed to differentiate it from other diseases. First step is the clinical evaluation. History and physical examination. The first step in diagnosing Cushing syndrome is taking a thorough medical history and performing a physical exam. A doctor will assess for characteristic features like moon face, buffalo hump, central obesity, thin skin, purple striae, and muscle weakness. Symptoms such as hypertension, hyperglycemia, osteoporosis, easy bruising, and mood disturbances. Differentiating from other conditions, the clinician will consider other potential causes for these symptoms such as obesity, polycystic ovary syndrome, PCOS, or alcohol use before proceeding to specific diagnostic tests. The initial screening tests for Cushing syndrome aim to prove that cortisol is abnormally high. These include 24-hour urinary free cortisol, low-dose dexamethasone suppression test, and late-night salivary cortisol. If cortisol remains elevated, further tests are needed to identify the cause. First test is 24-hour urinary free cortisol, UFC, test. Purpose is to measure the amount of cortisol excreted in the urine over 24 hours. Procedure: in this test, the patient collects all urine over a 24-hour period. Elevated cortisol excretion is suggestive of Cushing syndrome. Limitations of this test is stress, depression, or pregnancy can influence cortisol levels, so other confirmatory tests are typically needed. Second test is low-dose dexamethasone suppression test. Purpose is to assess whether cortisol levels are properly suppressed after the administration of dexamethasone, a synthetic steroid, procedure. The patient takes a low dose of dexamethasone and cortisol levels are measured the next morning. In healthy individuals, dexamethasone should suppress cortisol production. In Cushing syndrome, cortisol levels remain elevated despite the suppression test. Interpretation: if cortisol remains high, greater than 5 micrograms per deciliter, this is suggestive of Cushing syndrome. Third test is late-night salivary cortisol test. Purpose: measures cortisol levels at night when they are normally low. Procedure: saliva samples are collected late at night, usually between 11 p.m. and midnight. Elevated cortisol levels at night are abnormal and indicate possible Cushing syndrome. Advantage: it is non-invasive, easy to perform at home, and can be more reliable for detecting cortisol abnormalities compared to blood tests. After confirming excess cortisol, we measure ACTH to classify the cause. High ACTH means ACTH-dependent Cushing's, while low ACTH suggests an adrenal source. Then high-dose dexamethasone and CRH tests help differentiate pituitary Cushing's disease from ectopic ACTH production. To diagnose the cause of Cushing syndrome, we measure plasma ACTH. If ACTH is high, typically above 20 picograms per milliliter, the condition is ACTH dependent. This usually indicates a pituitary adenoma, known as Cushing's disease, or an ectopic ACTH secreting tumor, often found in the lungs. However, if ACTH is low, typically below 5 picograms per milliliter, the condition is ACTH independent. This points to a primary adrenal issue, such as an adrenal tumor or hyperplasia, where the excess cortisol suppressed ACTH production through negative feedback. High ACTH means look for a tumor in the brain or lungs. Low ACTH means look directly at the adrenal glands. Once we've confirmed that Cushing's is ACTH dependent, we must distinguish between a pituitary and an ectopic source. To do this, we use the high-dose dexamethasone suppression test. Dexamethasone is a potent glucocorticoid. In a normal body, it shuts down ACTH production. In patients with a pituitary adenoma, or Cushing's disease, the tumor is abnormal, but it still retains some sensitivity to negative feedback. Therefore, a high dose of dexamethasone will usually suppress cortisol levels by 50% or more. However, ectopic ACTH-secreting tumors, often found in the lungs, are completely autonomous. They do not recognize the feedback loop. In these cases, cortisol levels will show little to no suppression despite the high dose of dexamethasone. To summarize, if cortisol drops, think pituitary. If cortisol remains high, look for an ectopic source. When the results of a dexamethasone test are still unclear, we turn to the CRH stimulation test. CRH, or corticotropin-releasing hormone, is the natural signal from the hypothalamus that tells the pituitary to release ACTH. In a patient with Cushing's disease, the pituitary adenoma still possesses CRH receptors. When we administer exogenous CRH, these receptors respond vigorously. This leads to a robust rise in both ACTH and cortisol levels. A positive response here strongly confirms a pituitary source. On the other hand, ectopic ACTH-secreting tumors, such as those in the lungs, typically do not have these receptors. Because they are autonomous, they show little to no response to the CRH injection. ACTH and cortisol levels remain largely unchanged. After confirming Cushing syndrome and identifying whether it is ACTH-dependent or ACTH-independent, imaging studies are used to locate the source of excess cortisol. If a pituitary source is suspected, a pituitary MRI is performed. This helps detect a pituitary adenoma, which is the most common cause of Cushing's disease. If ACTH levels are low, this suggests an adrenal source. In this case, an abdominal CT scan or MRI is used to look for adrenal tumors or nodules that may be producing cortisol directly. If ACTH levels are high but the pituitary is not the source, doctors may suspect ectopic ACTH production. A chest CT scan can help identify tumors in the chest, such as small cell lung cancer, that may produce ACTH. In summary, imaging does not diagnose cortisol excess by itself. It helps locate the cause after hormonal testing confirms the type of Cushing syndrome. Treatment of Cushing syndrome depends on the underlying cause of excess cortisol. If the cause is long-term corticosteroid use, the doctor gradually reduces the steroid dose or changes the medication. Steroids should never be stopped suddenly because this can cause adrenal crisis. If the cause is a pituitary adenoma, the main treatment is surgical removal of the tumor, usually by transsphenoidal surgery. If the cause is an adrenal tumor, surgery may be done to remove the affected adrenal gland. If the cause is ectopic ACTH production, treatment focuses on finding and removing or treating the ACTH-producing tumor. When surgery is not possible or cortisol remains high, medications can be used to reduce cortisol production, such as ketoconazole, metirapone, osilodrostat, or mitotarne. Radiation therapy may also be used, especially when pituitary tumors cannot be completely removed. In summary, the goal of treatment is to lower cortisol levels, treat the underlying cause, and manage complications such as hypertension, diabetes, osteoporosis, and infections. Cushing syndrome is the clinical manifestation of chronic hypercortisolism. Essentially, the body is marinating in too much cortisol. Most cases are exogenous, caused by long-term steroid use. However, endogenous cases usually stem from a pituitary adenoma, which we call Cushing disease, or adrenal tumors. Look for the classic Cushing OID habitus. This includes truncal obesity with thin extremities due to proximal muscle wasting. You will see a moon face and a buffalo hump, which is a fat pad on the upper back. Most specific to Cushing are those wide, purple striae on the abdomen and easy bruising. This happens because cortisol breaks down collagen, making the skin paper thin. It is not just physical. Internally, patients face secondary diabetes because cortisol is gluconeogenic, and hypertension due to mineralocorticoid effects. You will also see osteoporosis and impaired wound healing. In women, look for hirsutism and irregular menses caused by excess adrenal androgens. To diagnose, we must prove the high cortisol levels first. We use a 24-hour urine-free cortisol test, a late-night salivary cortisol test, or a low-dose dexamethasone suppression test. If cortisol does not drop, you have confirmed the syndrome. Next, check ACTH levels to find the source. Low ACTH means the issue is in the adrenals. High ACTH means it is the pituitary or an ectopic source like lung cancer. Treatment depends on the cause, surgery for tumors, or a slow taper for those on chronic steroids.